Okay. See, let us start with the first MCQ here. First MCQ states that the geographic glossitis, or I mean geometric glossitis, is caused by. See, usually glossitis means whenever we come across geographic tongue. Okay, that's why I got this slip of tongue. Geometric glossitis is caused by. Basically, geometric glossitis means glossitis means inflammation of tongue. All of us know that occurs because of depapillation. Geometric glossitis means in certain areas of the tongue there will be depapillation. It looks like a map. Okay, how a globe or how a map will be there. Same way, certain areas of the tongue will have depapillation. That is called as geometric glossitis. Okay, remember, geometric glossitis is a characteristic feature of the herpes infection. Usually they say that you don't see in herpes geometric glossitis. Like, for example, usually herpes means what we come to know. Herpes, whenever we think of herpes, we either think of primary herpes or secondary herpes. Primary herpes means what? The patient will have basically the painful ulcers. Okay, that too, which is called as acute herpetic gingivostomatitis. Right? All of us know acute herpetic gingivostomatitis is the that you see in case of primary herpes. In case of secondary herpes, which is usually seen because of reactivation, usually you will see herpes labialis. It is secondary. This is what usually you see in case of herpes. And the ulcers will be usually affecting the mucoperiosteal area. That is why we have described gingivo, mucoperiosteal area. So masticatory mucosa, there you will see ulcers. That is how you differentiate the ulcers in herpes from aphthous ulcers. Aphthous ulcers typically affect the labile mucosa, whereas herpetic ulcers usually affect the mucoperiosteal area. Okay, that is a point you have to remember. Now, why I am discussing here this point about the primary and secondary is geometric glossitis means it affects tongue. It is seen in herpes. Not all cases of herpes will show. So herpes, if it occurs in immunocompromised patients, that too particularly HIV positive patients, in such cases you will see geometric glossitis. So geometric glossitis means you have to think of immunocompromised state or HIV positive patients. This is a very important MCQ that has been previously asked many times. Okay, so this is what you are supposed to remember about herpes. That acute geometric glossitis is seen in case of the immunocompromised patients or HIV positive patients in herpes. Candida, other options, let us see. Candida, HPV, vitamin B deficiency. Does Candida cause geometric glossitis? No, Candida usually doesn't cause any kind of geometric glossitis. Rather, it will cause sometimes acute atrophic candidiasis will be there, which can affect the tongue sometimes. Okay, acute atrophic candidiasis. This is called as antibiotic sore mouth. So that can affect the Candida. HPV, human papilloma virus, doesn't affect anything like glossitis. Vitamin B deficiency, yes, of course. Vitamin B deficiency causes geometric glossitis, causes glossitis. Like mainly vitamin B deficiency which leads to megaloblastic anemia or pernicious anemia. There you will see glossitis definitely. Okay, that's about the first MCQ. Now let us discuss about the second MCQ here. Salmon patches are, what are salmon patches? Keloid, dermatitis, allergy, vascular malformation. There are 4 options here. Actually, if you see this question, salmon patches are vascular malformation. Okay, fine. Now, what are salmon patches? Usually in children, it's a congenital thing that occurs basically. It's a malformation, vascular malformation only, that is usually seen in children, which is also known as sometimes angel's kiss or stork bite. Stork bite. Typically, you will see in children where you will see this salmon patch, that is because of dilated capillaries. Capillaries will be dilated. Because of that dilated capillaries, you will see this salmon patch. The most important difference between salmon patch and or the salmon patch and the port wine stain, if you see, salmon patch usually fades. The color of that fades over 1 or 2 years. That is, within 1 or 2 years, the salmon patches color fades. About that is not seen in case of the port wine stain. Port wine stain is a type of hemangioma. Okay, hemangioma. Salmon patch is a type of vascular malformation, which is also known as angel's kiss or stork bite. It occurs because of dilated capillaries. Typically, you will see in children. However, the most important point you have to remember in salmon patches is those color of that patch. It will fade over 1 or 2 years. It will not remain like that. However, that's the main difference in port wine stain. Port wine stain doesn't fade like that. That is on contrary. Just write down here. On contrary, what you have to remember? Port wine stain. What is port wine stain? It is a type of hemangioma. Port wine stain usually does not fade. This is the point you have to remember. Okay, let us move on to the next MCQ here. Okay, next question. In which syndrome are oral carcinomas observed? So there are syndromes here: Peutz-Jeghers syndrome, Gorlin-Gott syndrome, Gardner syndrome, xeroderma pigmentosa syndrome. Xeroderma pigmentosa actually is a syndrome only. So there, where you can see this oral carcinomas. Because in Peutz-Jeghers syndrome, you don't see oral carcinomas. Instead, you will see the intestinal polyps. Gorlin-Gott syndrome, you will not see oral carcinomas. Rather, in Gorlin syndrome, which is also known as the jaw cyst bifid rib never syndrome, you will see basal cell carcinomas. You will not see the oral carcinomas. Rather, you will see basal cell carcinomas in Gorlin-Gott syndrome. What are the other components of Gorlin-Gott syndrome? You will see bifid rib. You will see multiple odontogenic keratosis. Okay, and you can see the calcification of falx cerebri. All those things you will see. Okay, Gardner syndrome. Do you see oral carcinoma in Gardner syndrome? No. Gardner syndrome typically have jaw osteomas. Gardner syndrome patients typically have jaw osteomas. Xeroderma pigmentosa is the one where there is increased risk of what all things? There is increased risk of, in Xeroderma pigmentosa, increased risk of 3 things: melanoma, basal cell carcinoma, or oral carcinoma. Okay, so that is the importance of Xeroderma pigmentosa. You have to remember that there is increased risk of melanoma or basal cell carcinoma or oral carcinoma. Okay. Let us understand few things about xeroderma pigmentosa. Actually, why do you see xeroderma pigmentosa? The main reason for xeroderma pigmentosa is because of the defective DNA repair. Normally, we know that whenever DNA damage takes place, the DNA gets repaired. There is defective DNA repair. Why? Because there are certain enzymes called as exenucleases. Those exenucleases are abnormal here. Because of this abnormal exenucleases, defective DNA repair takes place. That leads to the xeroderma pigmentosa. Okay, that leads to xeroderma pigmentosa. Simply again we can write down XP. XP is xeroderma pigmentosa. It's a skin condition where there is increased risk for either melanoma or basal cell carcinoma or sometimes oral carcinoma. Okay. Let us move on to the next fourth question. Tongue metastasis is seen in. That means the deposits in the tongue. Lung carcinoma, skin cancer, kidney cancer, breast cancer. If you see here, in only in the skin cancer, you will not see this tongue metastasis, because usually skin cancers means either basal cell carcinoma or it could be melanoma or squamous cell carcinoma. Any of these usually do not cause the metastasis to the tongue. So just remember that. So if you see combination of these three, A, C, D is the correct answer. A, C, D is the correct answer. So usually you have to remember, whenever we see metastasis, usually tongue is not the most common site. Okay, actually the most common soft tissue site for metastasis, for METs, is actually, when we call METs means metastasis, is gingiva. Is gingiva. It is not the tongue, you have to remember that. Okay, the most common soft tissue site for metastasis is gingiva. Why? Because gingiva is always inflamed. So the inflammatory cells which are there will act as a seed for the deposition of the metastatic tumor cells. Okay, let us move on to the next question here. A radiographic image of a 12-year-old boy with multiple decayed teeth and a history of non-Hodgkin's lymphoma treated with chemotherapy and radiation showed certain findings. So that means a 12-year-old boy is there. Patient had non-Hodgkin's lymphoma. Child had the non-Hodgkin's lymphoma, which was treated. That is, after the treatment, this radiograph you can see. See, in this abnormality, if you can see here carefully, look at this. This is the abnormality. The size of the crown and roots have shortened here. Why the size of the roots and crown have shortened here? That is because of the treatment that has been done during the tooth development. So patient had non-Hodgkin's lymphoma. So because of the non-Hodgkin's lymphoma, patient was treated with radiation and chemotherapy. So that the teeth which were developing at that time showed the abnormality. What is that abnormality here? You can see carefully, the root is small and the root is small and the crown is small. That is called as stunting. Stunting. Okay, so this is the abnormality that you see called as stunt. Stunt means what? Stunt means whenever anything is very minute, smaller, that is called as stunting, that you see in case of the crown as well as root. Let us move to the next question here. Yes. Okay. Which of the following conditions is characterized by an epithelial lining that is uniformly thin, ranging from 6 to 8 layers? So first point we are getting here is epithelial lining is 6 to 8 layers. A basal layer with palisaded pattern, polarized nucleus, and a lumina which is parakeratinized, and that produces corrugation. So typically, if I have to compile all these things, there is a basal cells here, basal cells, tall columnar basal cells, and there are 6 to 8 layers, okay, and there is para-keratin corrugation, and this para-keratin corrugation typically, and these basal cells, if you see, they have got a palisading nuclei. This is a characteristic feature of OKC. So this is you have to remember all these points, that 6 to 8 layers will be there typically, and the basal cells have got, that is called a tombstone or picket fence appearance, and this corrugation that you see on the luminal surface is called as para-keratin corrugation. Remember, para-keratin corrugation is very characteristic feature of the OKC, because we have one more type of the cyst called as orthokeratinized odontogenic cyst. That is orthokeratinized. It is not para-keratinized. What's the main difference? Why we have to understand between orthokeratinized and para-keratinized is orthokeratinized is usually milder. Okay, it is not that aggressive behavior. It has got an orthokeratinized this one, and it doesn't have the typical picket fence or the tombstone appearance. And the most important one in orthokeratinized is it will have the granules, specific granules within the stratum granulosum. Okay, so that is what you have to remember in case of the OKC as well as orthokeratinized odontogenic cyst. Okay, let us move to the next question here. A 55-year-old patient presents with a slowly enlarged firm mass in the palate. So there is a palatal mass. Age is 55-year-old. Okay. Biopsy reveals a tumor composed of myoepithelial cells and ductal cells. Tumor is there. Tumor is having both myoepithelial cells and ductal cells. Okay. Before going to this question, I just want you to explain one thing. So whenever we discuss salivary gland, we discuss that there will be a duct, there will be any lumina or any structure. That lumina or duct is surrounded by one group of cells called as ductal cells. Outside this lumina, we have one more group of cells called as abluminal cells. So let us write down what are these cells. So the innermost cell that you see is a luminal cell, which is also known as a ductal cell. Outer cell is called as abluminal cell or myoepithelial cell. So normally you see combination of these two. Here also the question they are saying is that tumor is composed of myoepithelial cells as well as ductal cells. Morphologically, the tumor is exhibits basaloid epithelialness. That means basal-like. How do you see basal cells? Basaloid means, oid means basal cell-like. How a basal cell will have? A basal cell will have usually a dark hyperchromatic angular nucleus. A basaloid cell will have dark hyperchromatic angular. So this tumor is composed of basaloid cells forming cylindrical cyst-like spaces. That means it is forming cylindrical cyst-like. This is one cyst. This is inside. It has got multiple small cylindrical cyst-like spaces, which is called as Swiss cheese pattern. The lumina contains periodic acid shift positive mucosaccharide secretion. So this lumina will contain something like this, pass positive secretions. Additionally, there is evidence of perineural invasion. Which tumor is most consistent with these histological findings? So all these points, if you see characteristically, it's a feature of adenoid cystic carcinoma. Adenoid cystic carcinoma typically has got combination of both myoepithelial cells as well as a ductal cell proliferation. It has got multiple cylindrical cyst-like spaces, and those cyst-like spaces are filled with PAS-positive eosinophilic material, and this typical appearance is known as a Swiss cheese pattern. Swiss cheese pattern. That's a very important Swiss cheese pattern or classical pattern, histological pattern. You have to remember. And remember, the adenoid cystic carcinoma is the one which shows perineural invasion. Perineural invasion. That means, suppose there is a nerve, alongside the nerve, the tumor cells be spread like this. Because of this, there will be faster spread because of perineural invasion. There is one more tumor actually which exhibits this perineural invasion, that is the polymorphous low grade adenocarcinoma. PLGA also exhibits the perineural invasion. Remember this, which is also a salivary gland tumor that also exhibits the perineural invasion. Okay. Let us move on to the next question. Which condition is characterized by epithelial atrophy, atypia, Ritterage loss, basal layer degeneration, increased pigment containing cells, hyperplastic changes, dysplastic changes, lamina propria fibrosis, juxtaepithelial hyalinization? As soon as you hear of this word, juxtaepithelial hyalinization, you have to come across, definitely it is OSM. See, oral submucous fibrosis. What happens in oral submucous fibrosis? Mainly in this, there will be abnormal fibrosis. Abnormal fibrosis means increased collagen production and degradation is reducing. Because of what happens is, the epithelium, suppose this is the epithelium, just below the epithelium you will see the collagen deposition like this. That is known as juxtaepithelial hyalinization. And did I draw any epithelium like this? No, because there are no riterages here. Epithelium is very thin, it is atrophic, it is exhibiting dysplastic features. Okay, so that is what is about the oral submucous. And because of that fibrosis, the typical fibrosis that you see is called as juxtaepithelial hyalinization. Hyalinization means homogenization. And why do you see this hyalinization, homogenization? Mainly because of the growth factor TGF beta. So because of this TGF beta, transforming growth factor beta, there is increased collagen production and decreased collagen degradation. That leads to end result is fibrosis. Let us move to the next question here. A tumor presents with the stroma characterized by a diverse mixture of epithelial and myoepithelial elements. Again, same like adenoid cystic carcinoma, this is also having epithelial, myoepithelial components. Epithelial means ductal. Myoepithelial cells display variable morphology, appearing as angular or spindled or rounded with eccentric nuclei. They are either angular, they are either spindled or rounded with eccentric nuclei. Rounded with eccentric nuclei means, like I'll draw a diagram here for you. This is how you will see. This is called as plasmacytoid cell. Myoepithelial cell which is plasmacytoid. So you are seeing epithelial cells and you are seeing myoepithelial cells. Myoepithelial cells are angular, spindle shaped, or plasma settled. These cells are embedded in a myxoid, fibrous or hyaline background. Histopathology image is given there here below. You can see here histopathology image is given here below. Yes, you can see here there are ductal elements here. There is some pink material within this. There is myoepithelial proliferation. There are certain hyalinized area. This type of stroma that you see is called as chondromyxoid stroma. Actually, chondroid part is not seen here in this image, but this is a very typical stroma that you see in case of the PLG. So in this image, we are not able to see the chondroid area. What is chondroid? Chondroid means cartilage-like. Myxoid means loose areas. So here, the stroma that you see in case of the PLGA, there is polymorphous low-grade adenocarcinoma, will have usually it will be chondroid, or it will have myxoid areas, that is loose areas, or it will have lipoid areas, or it will have osseous areas, or it will have hyalinized areas. So usually of any of these you will see in case of the pleomorphic adenoma. So this is a typical pleomorphic adenoma that you see. So in case of pleomorphic adenoma, which is the most common salivary gland tumor, most common, let it be benign or malignant, that's most common, which is also called as mixed tumor, benign mixed tumor, which is a misnomer actually. Remember, it is mainly occurring in the parotid gland. Here you will see the proliferation of the epithelial cells and the myoepithelial cells, and the typical stroma that you are going to see here is called as the chondromyxoid stroma. Okay, let us move on to the next question here. Which of the following conditions does not show calcification of the falx cerebri? All of us know one which shows, all of us remember that as a syndrome is Gorlin-Gott syndrome. But remember, even in Papillon Lefebvre and Pseudoxanthoma elasticum, you will see calcification of falx cerebri. You will not see in hyperparathyroidism. This is just simple to memorize. There is nothing to discuss here much. So remember, calcification of falx cerebri are seen in three conditions: Gorlin-Gott syndrome, you are seeing Pseudoxanthoma elasticum, and Papillon-Lefebvre syndrome. What do you see typically in Papillon-Lefebvre syndrome? Papillon-Lefebvre syndrome will have the aggressive periodontitis. So you have to remember, these are the three conditions where you can see calcification of the falx cerebri. Again, a single liner MCQ. There is nothing much to discuss here. Which gene is not specifically associated with non-syndromic cleft palate? All of us know that there are cleft palates which can become a syndromic or non-syndromic. So which is not associated with the non-syndromic? PVRL1, definitely yes, it is associated. TGF alpha, yes, it is associated. IRF6, yes, it is associated. MTFHD is not associated. Remember, this we have discussed also. This is very important one. The PVRL1, typically, what is the importance of PVRL1? Remember, PVRL1 is the one which is gene that is mutated in case of ectodermal dysplasia plus cleft. Whenever there is ectodermal dysplasia plus cleft, that is because of this PVRL1 gene mutation, that is poliovirus receptor related 1, PVRL1 gene. Okay, rest all are TGF alpha, IRF6 and all that is associated with a non-syndromic. One which is not associated is the methylene tetrahydrofolate dehydrogenase. Okay, again a single liner MCQ which you have to remember. The next, Palatal papillary hyperplasia. What do you mean by palatal papillary hyperplasia? In the palate, there will be hyperplasia, which is clinically shown as papillary projections. Typically, you will see this in case of the Epulis fissuratum as well as candidiasis patients. So, combination of A and C is characteristic here. That is the correct answer. Not because of HPV. HPV doesn't show any papillary hyperplasia. Instead, HPV will show the papillary hyperplasia, but not of the palate. You will see wide projections, that too on the tongue. Okay. Focal epithelial hyperplasia or Hex disease again does not affect the tongue. Epulis fissuratum, that means it can be because of the denture, or in candidiasis also, where there is ill-fitting denture, you will see this palatal papillary hyperplasia. Which organism is not related to oral carcinogenesis? Oral carcinogenesis, actually, they say sometimes, see, these are not actually all these organisms that are there are not the primary organisms for oral carcinogenesis. That means they can lead to cancer. No, these are all secondary. Among this, lactobacilli is the one which does not cause oral cancer, because lactobacilli is the one which is associated with the deep dentinal caries. Deep dental caries. It is not that virulent which is involved in case of the oral cancer. Okay, so Porphyromonas gingivalis, yes, they have implicated actually it causes the aggressive periodontitis, Porphyromonas gingivalis. Helicobacter pylori, all of us know, which is related to the gastric ulcers and all those things that can lead to the sometimes oral cancer. Fusobacterium also has been implicated, but not the lactobacilli. Okay. Let us move on to the next question here. Yes. Which histopathological finding is indicative of a well-differentiated carcinoma in a leukoplakia lesion? That means patient had leukoplakia. In that leukoplakia, a well-differentiated oral cancer has occurred. Which is that feature that is suggestive of? Presence of epithelial hyperplasia without dysplasia, mild dysplasia confined to basal layer, severe dysplasia with the evidence of invasion. That's a simple answer. You can answer. Invasion is there. They are telling leukoplakia has got converted into cancer. What is the definition of a cancer? Oral cancer histologically. Oral cancer histologically, whenever we see invasion of the epithelial cells into the connective tissue by breaching the basement membrane. That is what is your invasion. So you are going to see the invasion that is nothing but severe dysplasia with evidence of invasion. It's a character. Hyperkeratosis with no dysplastic feature. Again, that's wrong. So sometimes why they have asked this question here is to tell you the most reliable histological criteria for cancer. What is that? Invasion. Okay. Let us move on to the invasion. Don't get confused. There are clinical invasion, histological invasion. What is clinical invasion? When a tumor, for example, in maxilla spreads or invades the maxillary sinus, that is called as clinical invasion. What is histological invasion here? Histological invasion means the tumor cells they will break the basement membrane and then enter into the connective tissue. That is called as histological invasion. Okay. Yeah. Let us move on to the next question here. Yes. Psoriasis is a chronic inflammatory skin condition characterized by well-demarcated red scaly plaques. One specific feature observed in psoriasis is development of new skin lesion on areas of trauma. This is known as Koebner's phenomenon. Simple. So when a Koebner in psoriasis patient, whenever there is a trauma, for example, patient is a psoriatic patient, there is a trauma or the patient scratches the skin, new lesion will appear there. And those lesions will be scaly, powdery, scaly. That is called as Koebner's phenomenon. So Koebner's phenomenon is also known as isomorphic effect. Remember, actually, Cobner's phenomenon is specific for psoriasis, but it can also be seen in, you can also see in, first of all, you can see it in psoriasis. You can also see this in lichen planus. You can see sometimes in case of herpes also, you can see Cobner's phenomenon. Okay, so whenever the word psoriasis comes, two things you have to remember. One is Cobner's phenomenon. Cobner's phenomenon is isomorphic effect, wherein whenever there is a trauma, in that area of the trauma, new lesions will appear. Histologically, you have to remember psoriasis means Auspitz sign. Auspitz sign. What is Auspitz sign? Auspitz sign is whenever these are the scaly plaques patches will be there. When you scrape off these scaly patches, you will see pinpoint bleeding spots. Those that clinical finding or that clinical sign of pinpoint bleeding spots on scraping the plaque is known as Auspitz sign. So the two important clinical findings you are supposed to remember. One is Auspitz sign. That is the clinical sign, and one more is the Cobner's phenomenon, that is the isomorphic effect. Okay. Let us move on to the last question for the discussion today. A jaw lesion exhibits the following histological features. Epithelial lining consists of basal layer of palisaded polarized columnar cells with hyperchromatic nuclei, with subnuclear vacuolization, with adjacent variable stellate shaped nuclei cells. The stroma appears dental papilla like, which is typical for atypical for ameloblastoma. What is the most likely diagnosis? If you see this, all these features are called as nothing but what? All these are nothing but your Vickers-Gorlin criteria. What is Vickers-Gorlin criteria? The basal cells, which are ameloblast-like cells, are tall columnar. They have palisading nuclei. There is a reversal of polarity of the nucleus. There is subnuclear vacuolization. All these are called as Vickers-Gorlin criteria. And Vickers-Gorlin criteria is a feature of ameloblastoma. Vickers-Gorlin criteria is actually a feature of ameloblastoma. These are all types of ameloblastoma will show Vickers-Gorlin criteria positive. Okay, so all other options are not type of ameloblastoma. Remember this. All others are not of the options for types of ameloblastoma. Okay, so that's a discussion for today's questions. These are the previous INICET questions for the subject of oral pathology. We'll have many such more sessions. I hope this session would have helped you. Any doubts in the comment section, you can ask me. Okay, thank you so much.